Welcome to another EduMed video in the series on the ITU ward round, and this is the final one thinking about how to propose a plan for your patient. We'll talk about an approach to how to write an ITU plan and then a structured ITU plan that works for most people. And then finally we'll touch a little bit upon the common mistakes that people make when making ITU plans. So the best way to approach a plan is to first of all have a problem list. Once you've got a problem list, you know the things that need to be addressed and you won't forget things. As I kept reiterating throughout this series, intensive care patients often have multiple problems, and if you don't put each of those problems listed down, you won't know whether you've missed something or not. So a common patient that you might get is a patient with a bacterial pneumonia. Now it's worth saying that that's a Staph aureus infection, and then you could even in brackets put in the culture and sensitivities to that. Then the patient has ventilatory failure, and you need to say about the status of that, so the patient's intubated and ventilated. This patient may also have some acute kidney injury, and then you should talk about the status of that. They're on renal replacement therapy, and you could even put in some results of what the acute kidney injury screen showed. The patient may have shock, so to say that they're on noradrenaline, and that they may have gut failure and they're not absorbing their feed as well, and they may even have some constipation as well, they haven't opened their bowels. So it's really important to have that problem list up, because only by doing so will you know the things that you need to address in your plan. After you've put a problem list, it's always worth just having a short paragraph just to state what the patient's status is. This doesn't have to be comprehensive, but it just gives people a flavour of where the patient is at. So if the person comes to read your review, rather than having to read through all the different aspects of the A, B, C, D, E, etc. review, they can just go to that last summary sentence and work out what the problem is. So you could say something along the lines of, Mr. X has a Staph aureus bacterial pneumonia, which caused ventilatory failure requiring intubation and ventilation. You could also put in that that they were admitted 3 days ago, or that they've been intubated for 2 days, for example. His ventilatory requirements remain static, so we've got a status there. That he's got septic shock with static noradrenaline requirements, so again, he's not really improving. He's got multi-organ failure, and that he depends on renal replacement therapy, and he's also got gut failure as well. And then the final sentence just tells people very shortly what's going on. He's got multi-organ failure with septic shock and a bacterial pneumonia. He has a static clinical picture. Just by reading this, immediately you've got a picture of the patient. Even though you've never seen the patient, you understand where the patient is at. And that is so useful for not just yourself, but also for the nurse and for the multidisciplinary team that will come to review the patient, including the patient's base team. And by giving that flavour of what's going on, people will be able to plan their investigations and their expectations appropriately. So in terms of creating a plan, there are 2 different ways that people talk about it. You can either do a systems-based plan, where you talk about each system in place, or a priorities-based plan. Most people in intensive care tend to go towards a priorities-based, only because it stops you from forgetting different aspects. And the priorities are targets, and then we talk about each of the systems in turn and the targets that you want to achieve. Infection, whether there is any, and the treatment plan for that. Investigations, that includes new investigations and chasing up of old investigations. And procedures, which again forms an idea of whether certain jobs need to be done at certain times, and also what jobs need to be done for the patient in total. And allows an easy tick list for when you're reviewing the patient in the afternoon to make sure that all of those things have been achieved. So when thinking about the targets for patients, then it's worth going through each system in turn. And you will see that when writing these plans, you will be covering the things that we were thinking about when we were doing our ABCD approach to the patient. So the first question is, can they be extubated if they're intubated? Is their oxygen getting better or worse? If it's not, we need to investigate it. If they're not able to be extubated, we need to think about how we can move the patient forward to a point where they can be extubated, i.e. what is stopping them from being extubated. In terms of targets, they're all fairly standard. So we want to aim for a tidal volume of between 6 and 8 ml per kilo. That's derived from the ARDSNet data and also from later studies as well. We want a driving pressure of less than 15 ideally. Again, go through my ventilation lectures to hear about what driving pressure is and thinking about atelector trauma, volu trauma and barotrauma. We want a PO2 of more than 8, but more importantly probably saturations of 88 to 92%. Aiming for a CO2 that gives a relatively normal pH, and if the patient is spontaneously breathing, making sure that it's sustainable, that they're not breathing at very high rates and therefore likely to tire themselves out. We want to always try and aim for a FiO2 of less than 60%. The reason for this is we want to try and prevent the oxidative stress on the lungs, which we know happens at high FiO2s. 60% is a relatively arbitrary number. We want it as low as possible, essentially. In terms of the cardiovascular system, the most important thing to ask yourself is what is their intravascular volume status? Should they get more blood or fluid, or can we actually start to take fluid off the patient? What is their cardiac output and what is their systemic vascular resistance? Can we augment their cardiac output with fluid or with inotropes, or can we augment their systemic vascular resistance with things like noradrenaline? But more importantly, are we over squeezing them? Have we increased their systemic vascular resistance too much? In terms of targets, we talk about a hemoglobin target of over 70. If they've got ischemic heart disease or evidence of ongoing ischemia, we may target higher hemoglobins of 80 or even 90. And mean arterial pressures, we want to target between 60 and 80 for most patients. Most people will aim at target a mean arterial pressure of 65. Beware, some patients who have chronic hypertension may require higher blood pressures to maintain an adequate perfusion pressure to their organs. We want to try and reduce their noradrenaline levels if they're on noradrenaline, but you need to ask yourself how. If the patient has a septic vasoplegia, the treatment is really to try and treat the underlying infection and to reduce inflammation. If it's that actually their volume deplete and they need more intravascular volume, then giving them that IV fluid may be all that's needed to actually improve things. Cardiac output monitoring is important, and we will talk about the targets of that in the cardiac output monitoring talk, so please have a look at that because it's a big topic in and of itself. In terms of the gastrointestinal tract, ask yourself, are they absorbing feed? What's their liver function like? Are they constipated? Do they need more laxatives or do they need less laxatives? And always think about infective diarrhea. Patients with multiple antibiotics are always at high risk of developing infectious diarrhea. In terms of targets, you generally want to aim for NG aspirates of less than 300 ml every 4 hours, and if they are getting more than that, think about giving prokinetics. Ulcer prophylaxis is vital for these patients. They're at high risk of developing stress ulcers, so if they're not on continuous feeds, then it's worth thinking about giving them a PPI therapy. In terms of the bowels, the ideal is to have 2 form stool per day. Now, if they do have a bowel management system in place to protect their pressure areas and to protect their skin from the soiling that's happening with diarrhea, then if you've got a bowel management system, make sure that they stay on laxatives because you need to make sure that the stool remains nice and loose for it to collect in the bowel management system and not to block it up. And finally, think about appropriate caloric requirements. They may need more calories, and the only way to really do that is by talking to your dietitians and seeing whether what you're giving the patient is adequate for their caloric requirement. From a genitourinary position, just as with IV access, always ask yourself the question, do they need a catheter? If a patient is completely anuric on the filter, it might actually be worth taking that catheter out for a while and then doing bladder scans to see whether the bladder is starting to fill up. Because if you've got a catheter in place, it'll only be a source of infection. If the patient is on a filter, it's worth asking yourself the question whether they can tolerate being off it. And the way in which we try to do this is by giving patients filter holidays. What this essentially means is that we stop the filter, wash it back, and then monitor the patient's renal function and urine output. And if they start to become more acidotic, if they remain anuric, or if they have a hyperkalemia, then we'd restart the filter. But if not, we want to try and see if they'll start to regain some of their native renal function. If they do have an acute kidney injury, always make sure that the screen has been done. And whenever you're seeing a patient on renal replacement therapy, always check the results of the acute kidney injury screen. You'll be surprised how often people miss things or haven't done an acute kidney injury screen before a patient has come in, before they've been started on filtration. And then afterwards, because the renal function has been relatively normal, no one's thought to do anything about the underlying condition. In terms of the targets, a sodium in the normal range is fine. The potassium between 4.5 and 5 is ideal to try and prevent arrhythmias, and often you find that below 4.5 patients can have an increased propensity to developing atrial fibrillation. Magnesium above 1.2 is useful again to prevent arrhythmias, and a phosphate above 1 is vital to try and maintain respiratory ventilatory muscle strength. And so if you're trying to wean someone off a ventilator and they're spontaneously breathing, hypophosphatemia definitely can cause muscle weakness and therefore make it harder to wean the patient off. Ionized calciums are important when thinking about vascular tone, so if you've got a patient who's on noradrenaline, make sure that their ionized calcium levels are appropriate, otherwise you might find that they become relatively more resistant to these vasopressors. In terms of urine output, you want to try and aim for 0.5 ml per kilo per hour, which roughly translates to 30 to 40 mils in the average adult. Every patient that you see, you must set a fluid balance. Even if that fluid balance is own, if the patient has got much better, they're in the recovery phase and they're autodiuresing, you can set it as their own fluid balance. But for most people, you need to set something. If they're stable and you think that they're clinically euvolemic, you can aim for neutral to plus 500. Plus 500 accounts for some of the insensible losses. Generally speaking, you go through a resuscitative phase for a patient where you might need 1, 2, even 5 litres of fluid to try and resuscitate them, and because they've got such vascular endothelial disruption, all of their fluid is just extravasating. However, once that endothelial integrity has been regained, as the infection gets better, as the patient gets better, you need to start drying them out. So once the patient is better, you're generally aiming for negative fluid balances. This can be as conservative as neutral to minus 500, but often patients can tolerate up to 1 litre to even 2 litres negative each day. I certainly wouldn't try to go any more negative than that, because physiologically you need time for equilibration between the extravascular and intravascular space. So if you try to take off too much fluid, either with frusemide or with the filter, you might end up with the patient becoming intravascularly too deplete and then unstable. When thinking about neurology, it's so important to ask whether the patient is oversedated. You want to try and aim for a RASS of 0 if you can. And sedation is really only there for tube tolerance and for safety. If the patient is delirious, the answer is not to sedate them more, but to manage their delirium. And we talk about the non-pharmacological and pharmacological management of delirium in the neuroassessment part of the ITU ward round, so I'd refer to that. Always important to ask whether the patient is in pain. If they're in pain, you must manage it. Uncontrolled pain will cause worsening of delirium. So in terms of commonly used targets, we commonly use a target RAS of 1 to -1. We want to make sure the patient has got regular analgesia and that the nurses are able to assess to see whether the patient is in pain, and if they are, that we give appropriate painkillers. And it's really important to think about opiate withdrawal. Often, patients who are intubated and ventilated remain on fentanyl for weeks. And if they are put on fentanyl for weeks and weeks, and then we suddenly stop it, patients can develop quite significant withdrawal, which may manifest as delirium. So if they do have that, do think about opiate withdrawal, and if you do think that is the case, then actually reintroducing a bit of opiate might well help with delirium. It's a decision that's based on a lot of experience, so make sure that you speak to an intensive care registrar or consultant before starting these interventions, because delirium is very difficult to manage in intensive care, and if it's done in an inappropriate way, you can end up making delirium worse and potentially stepping back the patient's recovery quite significantly. Infection is a really important thing to think about. You need to ask yourself, can you stop antibiotics if they're on them? Do not get into a situation where you're just continuing antibiotics on for weeks and weeks unless there's a set indication for it. These patients are at high risk of developing resistance, and if you continue them with antibiotic exposure for too long, they will develop resistance. You must always ask yourself whether there is an intercurrent infection, especially if the patient isn't getting better on the antibiotic or antimicrobial regime that you've started them on. Fungal infections are an important differential and often missed in patients, and these patients are at high risk of developing fungal infections. Do remember to chase your cultures. They can take a few days up to weeks to come back, and so always keep a note of all the outstanding investigations and then tick them off as they come back. Inflammatory markers are important to be monitored, but an increasing inflammatory marker in and of itself does not indicate infection, but it can be a good clue. So make sure that septic screens are done when there are signs of infection starting to brew, such as temperatures. Ventilator-associated pneumonias are really common and one of the most common sources of secondary infection on intensive care, and as such have a low threshold for investigating for one with either chest x-ray or with cross-sectional imaging, depending upon where it may be. In terms of targets, the full infection control procedures that we outlined in the previous talk are important, and certainly keeping the patient's head at 30 degrees or more is important in preventing patients from developing ventilator-associated pneumonias. Also, regular subglottic suctioning, regular mouth care, turning the patients, putting them on pressure, relieving mattresses, looking after their pressure areas and keeping their skin intact are all vital. Always ask yourself about what investigations are needed for the patient. When was their last chest x-ray? Do they need another chest x-ray? And then think about the best investigation, and that involves a balance of risk, which is involved with taking a patient out of the intensive care whilst they're intubated and ventilated, with the benefit. Say, for example, a CT scan may be much better at detecting areas of localized consolidation, especially things like behind the heart or in areas of effusion that you may not be able to pick up with a chest x-ray, which is a more simple bedside investigation. But then also ask yourself, could an ultrasound give you that same information? Timing of investigations is really important. If you've got multiple things that the patient needs to have done to them, think about when you want to have it done. Does it have to be that day? Can it be the next day? And so prioritizing your investigations is really important, because it gives you an idea of when to do which things. Because you will often find that patients need multiple things done, but it would involve them coming off the unit, and therefore other procedures may not be possible to be done. And always think about what procedures need to be done. Think about line changes, if a line has been in for too long, if the inflammatory marks are starting to go up. Always be able to argue why a patient has to remain extubated. If you can't give a convincing answer as to why a patient should remain intubated, then think about extubating them and optimizing them for that. If they need surgery or endoscopy procedures, try to time those appropriately with other things that are going on in the unit, and think about the priorities and the order of the procedures that you want to do. If a patient needs an OGD and also needs a laparotomy, it's worth talking to the surgeons, because maybe they'll be able to do both at once, so the patient doesn't need to go to endoscopy one day and then go to theatre the next day. You want to try and streamline the patient's treatments such that they have the least number of interventions and the least number of movements to try and prevent risk to the patient. So in general, with a plan, you've got to be systematic. You've got to go through each system in turn, give definite ways and methods in which to achieve the targets that you want. For example, achieve a PO2 of 8, increase their FiO2 up to 50%, and at that point call a doctor to review their PEEP. Will be a simple way to have a clear plan. You want to set targets and make sure that they're achievable targets. There's no point in asking for a -6 litre fluid balance, because that's not going to be achievable for that patient in a 24-hour period. So just take it time by time, and you can even go aim for example, for fluid balance, aim for -500 in the next 4 hours. And if you're not achieving that, then you can readjust your expectations. Always set plans that will move the patient forward. There's no point in setting plans that just keep patients static. If the patient has ventilatory failure and you've got optimized their chest physio, you've optimized their antibiotics, then you need to think about offloading the patient. There's no point in keeping a fluid balance on neutral to +500 if actually what you need to do is to offload the fluid in the lungs, and therefore diuresing them every day would be a more appropriate matter to try and get them off the ventilator, as an example. And finally, think about the timings of interventions. You have to try and streamline a patient's treatments throughout the course of the day. There's no point in trying to book lots of things in one day and only getting 1 or 2 things done. It's a waste of time both for yourself, for the nurses, and for the patient, as well as for the specialist teams that are involved. Try and organise things in a timely manner, and bear in mind that everything takes that much longer when patients are intubated. So a procedure that might only take 2 or 3 hours will probably likely take 5 to 6 hours, with thinking about moving the patient from intensive care, moving the patient in the area that they're in, for example surgery, and then moving them back to theatre, from theatre to the intensive care ward. So I hope you found that a useful group of lectures, and please go through all of them, because they all have little pearls and things that are commonly missed. The ward round is the most important thing in intensive care, because it catches all the problems and hopefully addresses them. By going through things in a systematic way, you'll be able to capture all the problems, and then with this lecture you'll be able to come up with a comprehensive plan that addresses each of those problems and also addresses those commonly missed things that you need to think about when managing patients on intensive care.